I will get that information to her. So again, any student who's received the first vaccine or both vaccines, if you'll just shoot me an email and I'll get that information to her, okay? Next, we're gonna start, let me share my screen. Let me hit record. Okay, let me share my screen. Okay, we're going to go over our matching that aligns with our cardiac meds. So the first, let's see, so number one, if you were to look at losartan, that is going to match to number 14. Sartans are angiotensin receptor blockers. They block directly at angiotensin 2 to prevent that peripheral vasoconstriction and as well as prevent the release of aldosterone. Okay. Number 2 is lisinopril. That would match with number 17. Your prils are ACE inhibitors, okay? You remember they block the enzyme ACE, which prevents angiotensin 1 from converting to angiotensin 2. So therefore you have it prevents that peripheral vasoconstriction, and of course it prevents the release of aldosterone, so you do not hold on to sodium and water. You do hold on to potassium. So these patients need to make sure they avoid salt substitutes because it can increase potassium levels, and that is why they are often combined with a mild thiazide diuretic such as HCTZ. Remember, your prils can have a side effect of a dry, hacky cough. The patient should not ever abruptly stop the med. They should call a physician and get that changed. They are also the ones where it has an adverse effect, especially with the African-American population, and that is angioedema. And of course, those patients are recommended to never take ACE inhibitors or ARBs again. Number 3, diltiazem. Diltiazem is, if you remember, that the matches to number 9. Number 9. Diltiazem and verapamil lack that chemical. So therefore, they work better at lowering heart rate. So number 9 is a calcium channel blocker that decreases conduction. So they work, diltiazem and verapamil, they work better to lower heart rate. Number 4 is metoprolol. So metoprolol is going to match with number 12. It is a cardioselective beta blocker, okay? Cardioselective beta blockers are your second generation beta blockers. So they are going to have more effect on beta 1 and less effect on beta 2, okay, metoprolol. Number 5, clopidogrel. Clopidogrel matches to number 11. Clopidogrel inhibits platelet aggregation as well as aspirin. Number 6 is warfarin. Warfarin, you are going to, it matches with number 10. With warfarin, you're going to monitor PT and INR. PT and INR. Number 7, furosemide, matches with number 7. Furosemide is a loop diuretic. It can be given PO and IV push. It is a very potent diuretic when given IV push. It works in minutes, and you lose potassium with not just sodium, but potassium as well with furosemide. So they have to watch their potassium levels. They may be on supplements, potassium supplements, or the physician may say to include, potassium-rich foods. Number 8 is hydrochlorothiazide. That is a mild diuretic that matches to number 18. It is the diuretic often given with your ACE inhibitors to balance out fluid and electrolytes. Number 9 is nitroglycerin. Nitroglycerin is a nitrate, so it matches to number 1. It's a vasodilator that can be given sublingual, an IV drip, and of course a paste. That can be the ointment is a short-acting paste. You give it like every 4 hours, every 4 to 6 hours. And then we also have the 24-hour patches now. So it's a nitrate, so it provides great, in particular, coronary vasodilation. Number 10 is clonidine. Clonidine matches with 15. It is an alpha-2 agonist. It blocks the alpha receptors in the brain. So clonidine can be given for hypertension or anxiety. Number 11 is tamsulosin. Tamsulosin matches with number 2. It is an alpha-1 blocker. Your OSINs are your alpha-1 blocker. Remember, tamsulosin is given for the treatment of benign prostatic hypertrophy, an enlarged prostate, to help enhance urinary flow. And if you remember, when you first start taking those, really any cardiac med, but in particular the alpha blockers, you have to watch very closely for orthostatic hypotension. So they should sit up slowly and not, of course, jump out of the bed. Number 12 is simvastatin. Your statins, that matches with number 3. They are a class of HMG-CoA reductase inhibitors, and that's how they lower cholesterol, by blocking this inhibitor right here, this enzyme. Heparin. Heparin is going to match with number 4. You're going to monitor PTT. And the reason I point that out is for state boards. Now, hospital facilities may use other tests such as the anti-10A, but for boards, we're going to look at the PTT. Your rivaroxaban, that matches with number 16. That is in the category of your new oral anticoagulants. The Exavans are factor 10A inhibitors. So that is how that's how they block the clotting cascade. Remember, with those meds, you do not have to have blood work. So, but not every patient is a candidate for those meds. And we certainly have to make sure insurance will cover that medication. Number 15 is propranolol. Propranolol is your matches with number 6. That is a non-selective, non-cardioselective beta blocker. It works as much on beta 1 and it does on as well as on beta 2. So those patients can have pulmonary complications, especially if they have a history of asthma or COPD, something of that nature. Amlodipine. Your dipines have that chemical in their makeup, so that matches with number 13. They are calcium channel blockers that work best to decrease peripheral resistance, peripheral systemic resistance, and therefore lower blood pressure. Your dipines. Number 17 is spirolactone. Spirolactone matches with number 5. If you remember, your spirolactone is an aldosterone antagonist. So it blocks aldosterone. So therefore you hold on to potassium. But it is your potassium sparing diuretic, number 5. This one I didn't talk about, and number 18 you do not need to know for the test. You'll learn more about it in 213. Your obeximab is your glycoprotein 2 inhibitor. It matches with number 8. Those are a class of medications that are given IV. IV drip. We use them in the cath lab after the patient receives a stent. So they, again, inhibit platelet aggregation. And then once the patient is stable, of course, we remove that and they go on out to the floor and start their oral antiplatelet therapy. Are there any questions about the matching?
Ms. Rumble, are you going to post the answers to that?
Certainly can. Mm-hmm. That's not a problem. Now, I tell you what I usually do is I just put the number by the first column, because when you start doing your lines, it can get confusing. So I'll just put like number 1, I'll put 14. Number 2, 17. So that way it's less confusing. It's more easier to see and interpret.
Thank you.
Uh-huh. Okay, so if there's no questions, then we'll go back to our slides of the altered cardiac perfusion. I can find it. It's down here in the bottom. Well, maybe I better just look it up here. It's in here somewhere. Reopen. Okay, hold on, guys. Having an issue, computer issue, so bear with me. Okay, I think I got it. All right, let me share my screen. Okay, so if you remember with our last discussion on Monday, we went over basic anatomy and physiology, and we looked at in particular, the pressures. Remember, the right side of the heart, which is right here, is a low pressure system. The left side of the heart, of course, is a little bit higher pressure system to pump all that blood out to the body to meet the body's needs. We looked at all the different vessels, the arteries that feed the heart. This is the right side of the heart. This is the septal wall down the middle, and this is the left side of the heart. And you'll learn more about that information, in 213. We looked at cardiac output. We basically, to summarize, we talked about how we want that very picture perfect Valentine heart with no occlusions, no plaque buildup, so that blood flow flows freely, so that the heart can pump all that blood out to the body. And then, of course, all of that comes back to the heart so that the body is getting the oxygen and blood flow it needs. We also learned that heart rate is governed by our autonomic nervous system. That's your sympathetic and parasympathetic systems. We talked about preload and afterload and what affects that. Certainly for the heart to pump adequately, it's got to have adequate intravascular volume. It's got to have venous return and good atrial contraction. This is often referred to as the rubber band theory, which will make much more sense when we talk about heart failure. So the heart, again, it pumps the blood that it receives. When you have that nice, beautiful Valentine heart, it's when you get coronary artery disease, myocardial infarct, uncontrolled hypertension, uncontrolled diabetes mellitus, that your perfect Valentine heart, which is our very taut rubber band, with diseased myocardium, such as COD, like I just mentioned, the heart enlarges to try to meet the body's needs. The brain sends a message to the heart, increase your heart rate, because I'm not getting enough blood flow. And the kidneys release renin, angiotensin 1 to 2, so that causes your peripheral vasoconstriction. What that does is increase the resistance that the heart has to pump against, okay? So over time, and of course, the body's holding on to sodium and water, cause of aldosterone. So over time, the heart will get bigger, okay? The ventricles will enlarge and the atrium will enlarge, and we call that hypertrophy. But what happens now, when it gets to that point, we no longer have our taut rubber band, T-A-U-T, tight rubber band. We have a very stretched rubber band. So the blood flow, you got less going out and less coming back, less going out, less coming back. And then you're going to see signs and symptoms that develop in your patient. As I mentioned, afterload is the resistance that the heart has to pump against. For example, if you have a COPD patient, their vessels in their lungs get very narrowed. So those patients will develop right side enlargement, which again, the heart works as a chamber. So when the right side enlarges, the left side enlarges. Also, we can have vasoconstriction of the vessels when, like I said, the body is not getting adequate blood flow. The periphery will constrict to try and get blood to the vital organs, but that only makes the heart work harder. Again, you want the very tight rubber band. You do not want the stretch rubber band because the heart is enlarged and it's not going to contract like it should. We're going to talk about these in just a minute. I'm just trying to summarize. All right, what are you doing? Electrical activity, we're not spending a lot of time with that. That comes in 213. These were just general terms you see in your drug book. What you need to take away from this is these 4 key electrolytes. They need to be within normal for the heart to pump at a regular beat. If they are hypo or hyper, in particular this one, potassium, it will cause dysrhythmias in the heart. You'll learn all about this in 213, okay? We talked about how the SA node, of course, pacemaker of the heart, because we want this adequate amount of impulses to meet the body's needs. So 60 to 100 beats is your preferred. However, hold on, guys. I don't know if I got the student in. Computer. Did I get her in? Okay, I must have. Okay, so that's, although, like I said, the heart will not stop pumping. It will, if the SA node fails, the AV node will kick in. And that is going to try and meet the body's needs, but we know that that's not going to happen because they emit impulses at 40 to 60 beats per minute. And if that fails, your Purkinje fibers will kick in. However, that is definitely not going to meet the body's needs at 30 to 40 beats per minute. Your nodes are located right here. You can see them where they're placed within the myocardium. And then we move to cardiovascular disease. Heart disease is the #1 reason men and women die in this country. However, COVID has surpassed that, but over time, I think COVID cases will come down, and this will continue to be a problem in this country. And the reason being this, we identified risk factors that we need to assess for in our patients who are complaining of pain or shortness of breath or, diaphoresis, because that chest pain can come in a variety of ways with your patient. So we said our non-modifiable, and then we talked about our modifiable. And this is where, as nurses, we do try to educate and make a difference with our patients. But many of our patients do not take care of their risk factors, and that is a problem. It leads to your plaque buildup, your atherosclerosis. So you were given a mnemonic that you can use to get more assessment data from your patient and vital signs to provide to the physician, okay? We know that with this, our physicians are going to order some labs. If you remember, your troponin TNI is going to rule out your myocardial infarct. You may see your creatine kinase myocardial bands ordered. Lipid profile. We'll talk about this more in a minute. And this is your brain natriuretic peptide. This is for heart failure. C-reactive protein is for inflammation. Of course, we can get chest x-rays and EKGs, stress testing, and cardiac catheterization, which I'll spend a little more time with in just a minute. So what do we take away from this? This is what happens, atherosclerosis, if risk factors are not addressed, and that can be modifiable and non-modifiable. You will get right here that plaque, you can see it right here. This is over years of time, how it just continues to narrow the lumen of the vessels. These are that causes inflammation. So these are your little, your platelets will come in here and, of course, try to clot, and that just makes this situation worse. The signs and symptoms, if you remember, will vary based on the percentage of occlusion. So that's why it's important for them to seek medical attention, because if this is like 100% occluded, that patient could have a myocardial infarction, which is irreversible. So that is not what we want to happen. So like I said, it's going to be the percentage of the occlusions in the vessels that will determine the outcome for the patient. So chest pain is known as angina. We talked about two types. Stable angina is relieved with rest and or nitroglycerin. Unstable angina is not relieved with rest and or nitroglycerin. They're both not good and should be addressed. This down here just again reiterates that angina can come in all different forms, depending on the patient. It may not just be the, elephant on the chest or the mid-sternal pain. You can have a variety of symptoms. So we also learned that ways as nurses we always rule out cardiac first. Things we can do for this patient, if their oxygen sats are less than 92 or 94 and or they're symptomatic, we're going to apply oxygen. We're going to give them a chewable aspirin to inhibit platelet aggregation. We're going to give them the nitroglycerin sublingual, 1 tablet every 3 to 5 minutes times 3. You should always educate your patients that one, if they don't get relief with the third one, they should call 911 immediately. 2, they always should keep their nitroglycerin in that brown little bottle. It helps keep the half-life of the med. So, and I always tell them, like, if you don't feel it tingle, then they probably need to get another prescription filled. So, of course, if they're in the ambulance or if EMS is there, they're in the hospital, then if they continue to have pain, we will also give morphine, 2 milligrams, which will also vasodilate some of the vessels and helps with anxiety as well. So we have to do a lot of education for our patients, as I mentioned on Monday. Give them handouts, educate when a family member is there or someone who is going to be able to help the patient with their plan. Okay, so then we talked about hypertension, the silent killer. We have millions of Americans really with hypertension, and they don't know they have it. And it's the #1 risk factor for stroke in this country. And this is your newest 2017 guidelines. And this is the ones I want you to learn because they're the most updated. And they've done this to help the physicians with treatment. So like I said before, if you have on 2 or more occasions have pressures within the elevated stage, then the physician may want to try diet and exercise, try to really say, you need to work on those risk factors and then come back and remember I talked about self-monitoring of blood pressure. That's a huge push now per the American Heart Association, is that people are self-monitoring blood pressure and they're taking their blood pressure properly. That is sitting down comfortable with their arm on a table so it's level with the heart. The cuff fits properly and their legs are not crossed. So that's a big push. Stage 1, again, your physician, I would think at that time, is going to start medication. And of course, it's stage 2, medication and risk factor modifications. It's 2 or more readings. So again, this is the big push per the American Heart Association, is taking your blood pressure properly. The number 1 cause of blood pressure is primary hypertension. We don't really know the exact cause. There's different research theories out there. You may see a patient with secondary hypertension due to one of these diagnoses. This is just some of your statistics to really push to you about how important it is for patients to get their blood pressure monitored. Many of our patients are walking around with these 20 millimeters higher on the systolic and 20 millimeters higher on the diastolic. And it is the number 1 reason for stroke. So we want to try and prevent that, because stroke is the number 1 reason for adult disability in this country. So we've gone over our meds, all of our meds. Other things we educate about is that low cholesterol, low fat, low sodium diet. They can go to heart.org and look at, they have great handouts there. It's the dietary approaches to stop hypertension. Trying to get an exercise program that they will adhere to. Walking is perfect. You do it 3 to 5 times a week. Moderation is the key, and stop smoking. So again, I reiterate this to you because we can help save lives. And that's why it's so important to educate, and treat, and make sure patients are adhering to their education, their plan of care, I should say. Okay, now we're starting. That was a summary of Monday. Now we're starting our new piece of content, and that is called heart failure. Heart failure is the number 1 diagnosis for patients over the age of 65. And those numbers are going to increase. Not just because the population is aging, but we will see the effects of COVID. Your generation will see the effects of COVID, and it's predicted to increase. Like I said, it's the number 1 reason patients over the age of 65 are admitted to the hospital. And not only admitted to the hospital, readmitted to the hospital. So it costs healthcare billions of dollars, heart failure. So what is it? To visualize this, like I mentioned earlier, your heart is now the stretched rubber band. So over time, of not addressing those risk factors. The heart enlarged, it hypertrophied, and now it's like this. Instead of this is what it's doing. So you have a continual cycle of the brain telling the heart to increase rate, of the kidneys releasing renin, angiotensin, aldosterone, okay? And that vicious cycle makes everything worse, but that's what the body does to try and compensate, okay? So the heart's having to pump faster, but it's pumping out less and less blood flow, less going out, less coming back. So then you have inadequate perfusion, and that's not good. Your latest statistics, 6.2 million Americans. And they do estimate more than 8 million people in the US because of heart disease, okay? And they say COVID is going to have impact on these numbers as well. Like I said, it's the number one cause of rehospitalization and greater than 50% in 6 months. You can see it's the average length of stay. And here you go, fastest growing cardiac disease in the United States. And there's tons of research out there. Okay, now I will tell you guys, heart failure, hold on. Somebody's got a question. Oh, computers, hold on. I have to stop sharing. I can't see the question happening. Oh, no. Are we responsible to know these statistics? No. It's to impact you the severity of the disease, okay? The severity of the disease. Those are the latest statistics. I am constantly on webinars for this topic, so no. But just to impact you of the severity of heart failure in this country. So the heart is like this. So when you have right side heart failure, you have left side heart failure. When you have left side heart failure, you have right side heart failure. But to help the student, the nursing student, learn what happens in the body, we separate it. So you can learn what really happens with the physiology behind it and why you see what you see, okay? But heart failure is heart failure. Now, there's two different ways to classify. The American College of Cardiology, and no, you do not need to know these stages. I just tell students you want to be in this stage, stage A, and not in stage D. That's the most advanced. The one you'll see, this the American Heart Association, A through D, or American College. I'm sorry.
You're not sharing your screen.
Oh, I'm so sorry. Computers. Okay, there you go. So as you can see, you've got two classification systems. Right here on your left is the American Heart Association or the American College of Cardiology. You don't need to know these stages, but you will see them addressed in the patients that you care for. So what I want you to take away from this, if you see stage A, well, then you know, well, that's better than being in C or D. And this one you'll see a lot. This is the New York Heart Association. You'll see it listed as stages 1 through 4. So if your patient's in stage 1 or 2, as a nurse, you'd say, well, that's better than stage 3 and stage 4. We have millions of Americans in stage 3 that you're going to see, okay? This is FYI. okay? But I have to include it because, 114 builds on 213. So what is ejection fraction? It's listed right there as EF. Ejection fraction is the amount of blood that is pumped with, and that's liters per minute. Amount of blood pumped, liters per minute. Okay, normal is 4 to 6, or you'll see 4 to 8 liters per minute. So normal is greater than 55%.
Where it says REF decrease 40%.
Yeah, let me explain. Okay, like I said, I want you to understand how they class systolic heart failure and diastolic heart failure. Now, to you, heart failure is heart failure, and you need to learn the signs and symptoms in the treatment, okay? How the physicians class systolic heart failure is when it's that REF means reduced ejection fraction, less than 40%. Why am I saying that? Because a lot of your new cardiac meds for heart failure are addressing the reduced ejection fraction, less than 40%, or systolic heart failure. You can have heart failure, it's called diastolic heart failure, where your ejection fraction is greater than 55%, okay? And they call that PEF is preserved ejection fraction. So a lot of our research is going into this systolic heart failure, where you have reduced ejection fraction, okay? There's a lot of meds that come up. Okay, now this you need to learn. Why do you see what you see? Okay, I'm going to start with right-sided heart failure. Okay, let me go over signs and symptoms and then we'll break. I'm going to start with right-sided heart failure, okay? Now, best way to learn this is back up the plumbing. So remember, on the right side of the heart, the blood comes back from the periphery to the superior and inferior vena cava, right? Goes into the right atrium, right ventricle, pulmonary artery, okay? So now back up the plumbing. So if you're a stretched rubber band and you're looking at the right side of the heart, you're going to see peripheral edema. Back up the plumbing. Peripheral edema. You can see ascites, or increase in abdominal girth. You can see liver enlargement and jugular venous distension. So back up the plumbing, and then you understand why you see what you see in these patients. Now with left side heart failure, remember, this is your heart now. Think about, where does the blood come from? It comes from the pulmonary vein into the left atrium, into the left ventricle, and then out to all parts of the body. So back up the plumbing. With left side heart failure, you're going to see crackles, cough, dyspnea on exertion, orthopnea. That means they cannot lay down to sleep. Okay, so you're going to get the pulmonary signs and symptoms. For hypertension, okay, this is a question about blood pressure. Okay, Okay, so the student's asking about the different stages. Okay, guys, I can't say for exactly what the physician would do. Okay, a lot of that's going to depend on signs and symptoms and what is actually going on with the patient. But just to help you understand why those 2017 guidelines were put into place, truly was to help physicians treat these patients better, more efficiently. So when the blood pressure is elevated, then usually they're going to try diet and exercise and see if, you know, the patient adheres to that and can get their blood pressure back down to normal. In stage 2 and stage 1 and stage 2, again, I guess what I'm saying is you should never just pop a pill. You know, you should always, as registered nurses, you have a job to educate. So even though we know they're going to be on medications, all of these patients need to try and adhere to a low sodium, low fat, low cholesterol diet. And that's, you can't just pop a pill. So I don't know if that helps make more sense. I'm just saying usually that the exact treatment for each and every patient will vary per what the physician believes this patient can do. So hold on, I have one more. Highly encourage watching a video on the blood flow in the heart to really grasp this. You should, yes, you're exactly right. So if you want to share that on your Facebook page or however you guys communicate, that would be wonderful, because I try to take all questions because other students may be having the same questions and may have, you know, need information from their peers to how they learn better. Okay, great. So she says she will post that on Facebook or wherever you guys get together. So like I said, to learn the signs and symptoms of heart failure, back up the plumbing, back up where the blood flow is coming from. Because we know now this is our myocardium. Okay, so everything's backing up. So back up that plumbing and you'll help you understand why you see what you see. Okay, I think it's now 1:50, so 5:10. We can take a 10-minute break. Is that okay, guys? And come back at 2. See the peripheral edema, the ascites. They can have increased abdominal girth, enlarged liver, and JVD. All of those are signs and symptoms of right side heart failure. And then, like I said, if you back up the plumbing and understand that, you know, the blood is coming from the pulmonary vein, left atrium, left ventricle. So with left side heart failure is where you're going to see the pulmonary signs and symptoms, such as a cough, crackles, orthopnea is inability to lie flat. They can be tachycardic, tachypnic. In your elderly patients, confusion due to the decreased oxygen levels. So again, that's what you're going to see in those when a patient is having signs and symptoms of left side heart failure. All right, so how are we going to manage this? Like I said, just if your patient's in A and B, I always say to them, it's better than C and D. And we do have many patients in stage 3 heart failure. So what are we going to do? Well, these patients are going to be on a lot of medications. The ACE inhibitors and your angiotensin receptor blockers are definitely have been a huge plus when they were developed, because like I said before, with a stretched rubber band, the body is not getting adequate blood flow. So the brain is telling the heart to increase the rate, and the kidneys are continuously releasing the renin, angiotensin, aldosterone system. That's just a compensatory mechanism. But that's only making the heart work harder. So by blocking the ACE enzyme, blocking angiotensin 2, that really can help the heart work more effectively. Again, you don't want them to have a high heart rate, but with the increased myocardial workload, the heart rate's going to go up. So that's where your beta blockers come into play, okay? And like I said, you have to look at your parameters. Usually it's going to say, like, do not administer if pulse is less than 55 and systolic is less than 90. So, but you'll see different parameters. Also, due to all that fluid buildup, we're going to see, probably depending on the signs and symptoms that the patient's having, furosemide. If they're at home, probably by mouth. They come into the hospital and, you know, you determine their priorities are their airway. Okay, they can't breathe. So that's when we give them that furosemide IV push, like I said, because it's going to work in minutes, and try and, you know, draw some of that fluid off, so we are protecting their pulmonary system, which is a priority. Heart failure patients, when they are discharged at home, you often see them on the potassium sparing diuretic, the aldosterone antagonist, the spironolactone. It is a mild diuretic, but it's more for maintaining normal potassium levels. That goes back to what I said about hypo and hyperkalemia will cause dysrhythmias to the heart. You'll see patients on different medications. Like I said, and we're not there yet, guys. I tell you, we're just not getting there. There's still increased numbers of heart failure. Now, this is the newest one of the new meds that are out, and they say it works. It's showing great promise. These are called your naproxeline inhibitors. They are a combination of an ARB, an ARB, and this naproxeline inhibitor. So if you'll look with me right here, you can see what this does. So it basically helps lower sodium, help the myocardium pump more effectively, and help dilate so that the resistance is not so high. You see this on television as Entresto. Entresto is its trade name. So it's a combination of valsartan, which is a sartan is an ARB, and this is the new naproxeline inhibitor. So you can see how it works and how that can be very promising for someone with heart failure. Big problem that we're seeing is insurance companies not covering this, but I think they're going to be jumping on the bandwagon more as we see more and more cases of heart failure. And that's your Entresto or the new naproxen inhibitors. Other things as nurses, we need to be we need to emphasize strongly the importance of monitoring their weight at about the same time every day with about the same amount of clothes, okay? Why is that? A weight gain of 2 to 3 pounds in 24 hours is a red flag for the patient. A weight gain of 5 pounds in 5 days is a red flag for that patient. So they need to be weighing themselves daily at about the same time each day with about the same amount of clothes. And they should write that down. We know if when our patients come into the hospital, so they're in fluid volume overload, they have decreased cardiac output, they're showing signs and symptoms of right and left side heart failure. We're going to be, of course, doing a chest x-ray, EKG, but we're also going to draw a BNP, that brain natriuretic peptide, okay? The other one you may see is the NT, pro-BNP. They're the same thing. It's just a better tool. I have seen levels, you can see that says their watch values 100 to 400. I have seen levels in the 2000s to indicate heart failure. Of course, we're looking at our chest x-ray for fluid in our pulmonary system and an enlarged heart. Always, of course, of most of these patients, guys, you're going to have to keep the head of bed elevated for them to breathe more effectively. Watch them for signs of overload. Once you get them through that acute state, that's when you give them your handouts, your written material about a low sodium diet, okay? It's imperative. The American Heart Association for patients diagnosed with heart failure recommends no more than 2 grams per day. 3 grams is the max. And if you think about that, if you start looking at what's in sodium's in everything, that can be a very difficult diet to adhere to. So, but that's what they recommend. Again, activity is essential, but they should develop a walking program. And then if they get short of breath, they sit down immediately. You know, they really have to be monitored with that. And some of our patients, they don't get any better, and they end up in palliative care and even hospice care for what is called end-stage heart failure, okay? And they have chosen that to be their choice, and that's okay. It can be very debilitating, especially if they're in stage 4 heart failure. Now, this is something that you will see. These patients come into the emergency department with acute decompensated heart failure or pulmonary edema. So they are in such fluid volume overload. Their O2s are dropping, their O2s are plummeting. They can't breathe good. They can have altered LOC, tachypnea, tachycardia, they've got decreased perfusion. And essentially, if we can't get some of that fluid off of them, they will end up being intubated and on a ventilator, okay? So this is where we're going to give our furosemide IV push. I've given up to 160 milligrams IV push. You can also give a furosemide drip to try and get this patient to pee, off that fluid. And just remember, guys, it's not just about fluid. You've got to monitor electrolytes, especially sodium, potassium, calcium, magnesium. Extremely important for us to do that. So that's going to be our big intervention. Of course, head of bed up, oxygen. Don't worry about the dobutamine and milrinone. You'll learn about those in 213. Those are actually to help the heart pump more effectively, but don't worry about those. These patients can go into cardiogenic shock because the heart can't pump effectively, and it just backs up. It just backs up, and it's very sad, very, very sad to see. And again, they can be in and out of the hospital, which is why it's so important that they take their meds as prescribed, that they get physician follow-up care, that they weigh themselves daily, et cetera, et cetera, et cetera. Adhere to the low sodium diet. I mean, it's a lot. It's a lot. And plus they're on a lot of meds. So it's not easy for them, but it can keep them out of the hospital, and that's what matters to us as nurses, that they stay out of the hospital. Okay, let's look at our patient. 67, awakens from a sleep. She sits up. This is typical. This is usually what I ask. She's trying to catch her breath. She's already laying on 3 pillows. A lot of our heart failure patients have to lay on 2 pillows, or they sleep in a chair. And so she's having a hard time. So her husband, of course, is now awake, and he's fed up. Nobody's getting any sleep. And he takes her to the hospital. So I'm looking for any signs and symptoms of right and left side heart failure. That's what I'm basically looking for. So I definitely know I have the shortness of breath, the labor breathing. There's my O2 sat. My heart rate's elevated and it's irregular. So I'm concerned about that low oxygen level. I'm concerned about the myocardial demand with that heart rate being elevated and irregular. I'm concerned about her electrolytes, and respiratory rate is unacceptable. I mean, it's just unacceptable. So, we're going to put her up 90 degrees. We're going to put oxygen on her. We're going to order stat for chest x-ray. We're going to get an IV in, and we're going to get an EKG and probably a BNP, and also a basal metabolic panel. I'm concerned about her electrolytes, okay? And I want a IV diuretic. I need an IV diuretic. And depending, this patient's 67, and with her being short of breath and with a respiratory rate that high, I would be very uncomfortable with her going to a bedside commode. So I would probably want to put a Foley in initially. I continue with my assessment findings. So there's your left side heart failure. Okay, what is S3? S3 is a gallop, okay, that you hear with your stethoscope. It is often indicative of left side heart failure, but again, I'm going to continue with all my assessment findings, looking at the big picture. So, but this could indicate left side heart failure. And of course, here's your edema in her legs and JVD. So there's your right side heart failure. All right, so looking at her history, so I've done all that. Hopefully I've got that IV push Lasix in her. Now we find that she had a myocardial infarct 5 years before. She has been treated with class 2, so that's good. That's not bad. And we do have some genetics in here as well. So she's just got a lot going on. And why? Because why does she have breathlessness? Because all of that fluid volume excess is impairing her pulmonary system. And what do I mean by that? I mean, her heart's enlarged. And you back up the plumbing, then as you get more and more fluid volume in your body, the body can't handle it. And that what happens is the capillary membrane is no longer intact. So the fluid seeps into the extracellular space and it seeps into the alveoli. So now we not only have a cardiac issue, we have a pulmonary issue. Physician's orders, I went over that. I'm going to stay with her. I'm going to have her on the monitor. I'm going to be watching her respiratory assessment and cardiovascular assessment very closely. Certainly going to be watching her urinary output at least every hour. Want to get my electrolytes back. I may have to give potassium supplements. With her condition, I would want to do that IV piggyback, potassium supplements, and just really getting her through this acute state, okay? What do I want? I want her heart rate to come down. I want her O2 sat to go up. I want her respiratory rate within normal. It'll take time. I want to see a decrease in crackles, but it's going to take time for her to get rid of a lot more fluid. So she's going to buy a few days in the hospital to watch her and make sure that she understands how important it is to weigh herself daily. All those things that we just discussed about keeping these patients at home. But they're in and out of the hospital. They truly are in and out of the hospital. And of course, you know, right now that's not good at all. Here are just stats. Again, you don't need to know this. It's to emphasize how much of a problem this is. These people, like I said, with class 4, you will see them in palliative care and hospice care, if that is what they choose. They feel helpless and powerlessness over the disease process. Heart failure with acute myocardial infarct, which was just like your patient that we went over, she has a 40% mortality. And that's why I keep saying to you, it is so important as nurses to try and teach and document and keep these people at home. And you can see 42% mortality at the 5-year mark. So each time they come in that hospital, they are increasing their chance for mortality by 22%. So that's just to emphasize to you why it's so important for them to do what the physicians and the nurses are trying to educate them about, okay? This is your evidence-based practice. Like I said, this is solely FYI. I'm just letting you know what is out there because eventually you're going to see these measures take in place, especially for the heart failure reduced ejection fraction. They're currently recommending triple and quadruple therapy with medications, with the netpresaline inhibitor, with the beta blockers. They call them, this is your, don't look at that, that's your aldosterone antagonist. You'll often see it listed as MRA, and it stands for mineral corticoid receptor antagonist. That's your spirulactone. There's that other one I was telling you about, or I was trying to think of. They're also looking now at studies giving an SGL2 inhibitor. If you didn't, that's in that, within that class is Jardiance, especially when our patients have diabetes type 2, which many of them do. And then they're even doing research on this one. I'm not even going to say it, but it's a selective myosin activator, basically trying to promote cardiac myocontractility. Okay, so enhanced contraction of the heart with a medication. So that's pretty exciting stuff. Other things we do see, especially for our patients that are in the stage 3 and stage 4, you may see them with an internal cardiodefibrillator because their stretched rubber band is so stretched that they have a lot of dysrhythmias, like lethal dysrhythmias. And so that will defibrillate those dysrhythmias. It can also pace the heart. Why do we pace the heart? That's called cardio resynchronization therapy. They actually put these little wires to pace the right ventricle and the right and the left ventricle. And that's to give better synchrony, okay, with that patient's myocardium, even though, and hopefully, pump out more blood going out, more blood coming back. Because what happens with that stretched rubber band, you get like this. So that cardiac resynchronization therapy can help give a little bit more synchrony to the contractions. We are seeing more use of left ventricular assist device, where they actually go in and put a pump, 2 little pumps in the heart to help pump blood more effectively. They wear a battery pack, and usually that's going to be, though, in the maybe palliative cases to give them, a little more quality of life, okay? So heart failure is a biggie. You will definitely take care of patients with heart failure in your nursing career. So let me take questions at this time. Now, also, I'm going to spend a little more time on cardiac catheterization. I felt like I rushed through that. No questions? Did you understand it? Everybody in time? Oh, I always stay for this, Dan. Yeah, it's a lot of material. To be honest with you, I worked on the exam this morning, and I will have that blueprint up. How I encourage my nursing students, especially you're entering second year, and it's a big step, okay? You have got to apply, okay? So I'm big on, like with your cardiac meds, I'm real big on index cards. I tell my seniors that, I said, that's how I learned meds. I didn't have drug cards. I didn't have all that mess, but because it forced me to write stuff down, it made it visual tactile. And not just that, my students are very busy this day and age. Drug cards, things like that can go in your pocket. So when you're, maybe you have time somewhere, wherever you may be, maybe you're sitting in the car line trying to pick up your kid, you can pull out those drug cards, and that gives you additional application time. And again, it's not about just knowing the medication. What I always tell my students to do is you write out the medication, you put down samples, okay, and on the back, you you need to say to yourself, what did Ms. Rummel say is so important about this med? What are the side effects? What do I have to monitor with my patient? That's what has to go in the back, not just this is a calcium channel blocker. Mm-mm. You've got to apply that information to the patient. So I would do that. You know, continuously just keep applying. Now, with the diseases, you've got to know risk factors. Okay, we've gone over risk factors. You have to be able to assess a patient for risk factors. And once you determine those risk factors, what else are you going to do? You know, you got to think about, okay, so this patient's got risk factors. I'm concerned. So I would go through their history, physical exam. I would want to know, are they complying with are they treating those risk factors, or they're not treating those risk factors? That's a huge difference right there. So I'm still, I'm going to say, you know, tell me how you feel. What kind of signs and symptoms do you have that brought you in today? And I'm going to look at that, and I'm going to say, you know, do you have pain? If they have pain, I want to know more about that pain, because I worry about angina. And then if it's angina, I worry about, is it stable or unstable? And what do you do for it? You know, have you already been diagnosed with cardiac disease? So what you have to do is apply this information. Okay. So what I often tell my seniors is, so take your patient, okay, have them come in the hospital or have them come into the doctor's office, okay, and then write out, you know, here's my patient. What am I going to assess for? You go down your list. What am I going to assess for? Cardiac cath always has to be ruled out first. So are they having angina? Was it stable or is it unstable? And do I know the difference in that? Okay. Do I know what labs I'm going to anticipate? Do I know what blood work I'm going to, labs I'm going to anticipate? What treatment measures? Do I know MONA? Do I know what it means, and why am I doing that? Same thing for hypertension. Same thing for heart failure. And the big difference is, you've heard me say it time and time again, educate, 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 educate. And you need to do all that before you ever sit down for this test. Okay? Now, one diagnostic test that I wanted to reiterate is cardiac catheterization, because a lot of these patients will go for cardiac catheterization. And that is an invasive procedure. Okay, you have to have a consent. And they are going to, you as a nurse, to keep, you have to remember, safety is imperative. So as a nurse, you've got to first say, you have any allergies? What are they? Do you have allergies to, any iodine in shellfish? Da-da-da. Get your labs. What is their creatinine level? If it's 2.0 or greater, the team needs to know, because that dye is toxic to the kidneys. And the only way to get rid of that dye is through fluids. They will go in, they will have their procedure done based on what they find. More and more patients now are having stents placed. So if I know that they're back there, they're getting a catheter either in their radial or femoral vessel, how am I going to take care of them and keep them safe? Well, I'm going to watch for internal and outward bleeding. Okay. I'm going to monitor their vital signs, and I'm going to monitor their pulses distal to the site. Because that catheter is not a tiny piece of toothpick. It's a good sized catheter. And if I cannot feel a pulse, as nurses, you better get a Doppler. You don't just say, we're doing the pulse. You get a Doppler. I'm constantly assessing that site. So I don't cover it up. I never cover up my site initially because I have to see if there's internal or outward bleeding. I've got to assess that extremity below the site. Is there, when they come in to me, do they have good cap refill? Is that foot cold? Well, it shouldn't be cold if it's got blood flow. So constantly monitoring these patients is extremely important to keep them safe. You've got to apply to help with study. I heard everything else, but not if you said, yes, I did say met cards. I strongly recommend index cards. That's how I got through nursing school, is index cards. Okay, and not just for meds. I would have my cards, care of the patient with heart failure, and I have my stack. Care of the patient with coronary artery disease, I'd have my stack. Care of the patient with hypertension, and I would have my stack. Because those cards can go with me. And that's important, especially for my students today, is time. And so by doing that, you can be pulling those out, going over meds, going over heart failure, going over CAD. You've got to apply. That is the difference in first year and second year. Will we need to know that flat time for femoral cath? No, you do not for the test. Just so you know, it's about 6 hours. And our biggest complaint is back pain. Back pain. That's why we're doing more and more in the radial vessel, if it can be done that way. I will be giving you a couple more assignments. Let me get what time is it? Hold on, let me get the calendar. Okay, so we will have February 1st. Wow, it's coming up quick, isn't it? So because we only have February 1st, it's a lot, but I'm going to go through vascular disease, okay? So you at least have that material. And then once I go through vascular disease, I'm going to post 2 more assignments for you to also help you apply and learn material. Okay, and then on February 1st, we will go back over heart failure and vascular disease, okay, as you prepare for the exam on the 3rd, okay? Anything else? Okay, so continue with your slides. Now we're talking about the periphery, the vascular disease, okay? Before I even start this, now the easiest way to learn this. Now, first, you will often see what we call an umbrella term, and that is peripheral vascular disease, okay? Don't think of that, okay? Just throw that out of your mind. You want to learn this by looking at peripheral arterial disease and peripheral venous insufficiency. That's the best way to learn this. Peripheral arterial disease and peripheral venous. Oh, I'm sorry. Sorry. Thank you. I forget. So the best way to learn it is to have two classes. Peripheral arterial disease, that would be a stack of cards, and peripheral venous insufficiency, and have a stack of cards, okay? So guess what? What's the cause of peripheral arterial disease and peripheral venous insufficiency? Atherosclerosis. Okay, same old. Risk factors. Again, the advanced age, 65 and older. Or I'm sorry, I put that under there. If you didn't know what LEAD, it's lower extremity arterial disease. So we're going to talk about peripheral arterial disease, okay? Now, who's most at risk? Certainly folks with the modifiable risk factors, but in particular, the non-modifiable advanced age, smoking and diabetes are really bad on the periphery, okay, really bad, as well as obesity and sedentary lifestyle, okay, because you're. All right. So other risk factors for peripheral arterial disease. We do see a genetic tendency for this. We see it in uncontrolled hypertension, uncontrolled high cholesterol. We do see it more with the male gender. And you can see cardiovascular disease accounts for over 75% of deaths in patients with peripheral arterial disease. Okay, now remember, this is your peripheral arterial disease. Think of the arteries. What do the arteries do? They pump blood to the feet, okay? So you got that blood flow going down the leg to the feet. So a hallmark sign of peripheral arterial disease is this: pain that's triggered by exercise and relieved by rest periods. And that is called intermittent claudication, hallmark sign of peripheral arterial disease. Because that blood, think about it, guys. It's just like, you remember how we talked about the clogged vessels in the coronary, in the myocardium? Well, these are clogged vessels in your peripheral arteries. So with exercise, that blood flow, in other words, it's not meeting the body's needs, the periphery's needs. So they get pain, especially when they exercise, usually relieved by rest. As it gets worse, it's not relieved by rest. So they can complain of cramping, muscle tightness, depending on the extent, just like with the myocardium. Remember I said it was the percentage of the occlusion. Same thing with this. Depending on the extent of the arterial disease determines the signs and symptoms. There are patients that could be symptom-free. So think of this as this. So that artery is narrowing, okay, due to plaque buildup. And then again, as that increases over time, then rest is not going to relieve that pain due to the decreased blood flow and oxygen. So with peripheral arterial disease, you're looking for intermittent claudication. You're also, think about it, what are you going to tell your patient things they can do to decrease pain? Well, we want them to hang their legs down. That way, let gravity help enhance blood flow, okay? So that's why we're keeping the legs down. Don't cross the legs, okay? They can sit down and just keep them down, both feet flat on the floor. So again, allowing that gravity to enhance some blood flow and oxygen. You should always assess pulses, okay? Cap refill, absent pulses, cold feet should be reported. Cap refill greater than 3 seconds needs to be reported. Now, you can see diabetes, smoking, hypertension. These are deadly to the periphery. Test that you may see done is called the ankle brachial index. So they look at basically the difference of the brachial pressure and the ankle pressure. You do not need to know this. Just remember that term, ankle brachial index. You will see, could see that on NCLEX. For most of us, these patients in the hospital are going to get the Doppler color flow study. They're going to actually look at how much blood flow is going through to the periphery. So as nurses, you assess for that pain, that intermittent claudication, lack of feeling, check their pulses, cold feet, delayed cap refill, all those have to be reported. So what are we going to do for this patient? These patients are placed on antiplatelet therapy. Again, we know when our vessels have plaque formation, the platelets adhere due to the inflammation and make the situation worse. So we give them antiplatelet therapy to try and prevent platelet aggregation and improve blood flow, okay? We need to do our education. I've said that time and time again about controlling their risk factors. They do need to walk, but they need a gradual walking program and stopping, of course, if they have pain. So it needs to be a gradual program. In the hospital, even at home, you may see them with the old TED hose. In the hospital, you'll see them with the SCDs, those types of things. Okay, many of our peripheral arterial disease patients that are diagnosed with that will have like the TED hose at home, either full length or half length. So most of our patients are treated medically, but if the disease process is significant, remember, like I said, if they have like a 90, 95, 100% blockage, they can also go into the periphery and perform that percutaneous transluminal angioplasty. The balloon, and they even have stents now, guys, that will go in the peripheral vessels. So we're getting better with that. Back in my day, they would have to have like a bypass where they would take a vessel and actually attach it to the abdominal aorta and then go below the blockage. But now with the increase in the number of angioplasties and stent placement, that's helping a lot of patients not to have that surgery. That is a very serious surgery, aorta femoral bypass and aortic iliac. If left untreated, if they do not do risk factor modification and take their medications and do a gradual walking program, and you can see eventually it can lead to basically no blood flow and oxygen to the periphery, and that will result in gangrene. And you can see here it's 10 times faster in patients with diabetes and 3 times faster in patients who smoke. So it's those in particular who don't stop smoking and don't control their diabetes. They have no clue what they're doing to their coronary vessels. They have no clue. Some people do, but some don't. Okay, so I reiterate, that's your first, peripheral arterial disease. Signs and symptoms of what you see and how to treat. Now we're going to your second set of cards, and that's peripheral venous insufficiency. And you know what? We've got time. Let's go ahead and take 2:50. Let's go ahead and take a 10-minute break. We'll come back around 3, and then we'll continue with our peripheral venous insufficiency. Get through. Oh, hold on. I forgot to hit record. Okay, now share my screen. Okay, so before we talked about peripheral arterial disease. Now we're talking about peripheral venous insufficiency. And the big complication of peripheral venous insufficiency is a deep vein thrombosis, okay? Patients that have venous stasis, vessel wall injury, and altered blood coagulation, that's actually called Virchow's triad, which is what patients with venous insufficiency have. We also know patients that are on long periods of bed rest and have venous insufficiency are at great risk for a DVT. Large bone surgery, again, you're at risk for DVT. Obesity, pregnancy, as well as oral contraceptive use. So a lot of our patients that have venous insufficiency and are on bed rest or have the others, maybe they're listed, are at much higher risk for developing a DVT, which can be extremely dangerous. So we want to prevent this, in particular when our patients have venous insufficiency. Now, with venous insufficiency, you're going to see the results of that in the lower extremities. Okay, you're going to see foot and ankle edema. They may have some pain, but it's not due to their venous. The pain is more due to the edema. Okay, let me try to keep this straight. It's more due to the edema and the venous pulling because they have venous stasis. So therefore the blood does not go back up the leg like it should. So they have venous pulling, venous stasis. They will have brown, discolored skin, and in particular hair loss. because think of the blood flow. The veins bring blood back. So now that blood is not going back up the leg. So how do we enhance the blood to go back up to where it belongs? Well, we know our compression hose, our SCDs, enhance that flow back to the heart. These patients, because a deep vein thrombosis is a serious, or can be serious diagnosis if it's not caught in time, these patients are on anticoagulants to try and prevent a clot from forming. So they may be put on your sub-Q heparin or your sub-Q low molecular weight heparin, which is your enoxaparin, to try and prevent a DVT from occurring, okay? Now, with these patients, you're going to allow gravity to help you as well. So we're going to elevate the feet above the heart, trying to promote that blood flow back to the heart. So they should certainly do exercises to enhance blood flow back to the heart. So again, early ambulation is important to enhance blood flow. We don't like for these patients to sit for long periods of time due to that venous pulling, venous stasis, edema. So we don't like them to sit for long periods of time because that's just going to promote more pulling of blood. So we like for them to get up and move around periodically. In peripheral arterial disease and peripheral venous insufficiency, they should not cross their legs. All right, so what are you going to see if the arterial disease or peripheral venous insufficiency is significant? You're going to see ulceration from lack of blood flow and oxygen, okay? We're not going to look at treatment. Treatment is, there's so many, it's not even funny. So, but my point being, without adequate blood flow and oxygen that is significant, you're going to get infection and probably it can lead to gangrene and loss of a limb. So when we see ulcerations, we know that protein is essential, vitamins and minerals for healing to occur. Okay, now let me try to explain this. Think of with peripheral arterial disease, like I said, the blood flow is not going down to the foot, okay? So the arteries deliver blood flow down, okay? So because of that, you're going to see ulcerations like on top of the toes. Okay, think of that. You'll see the ulceration more on top of the toes because it's not getting the blood flow and oxygen downward. With venous insufficiency, you're going to see the ulcerations more on the ankles or on the bottom of the feet. Just like, you know, a lot of these patients have to go to a wound clinic if it's significant to try and heal these ulcerations. With our arterial ulcerations, our main priority is to enhance that blood flow back to that extremity. And hopefully they won't lose, you know, a toe because of it. But with venous insufficiency, they can have more of your typical ulcerations on the ankle and the bottom of the feet. That again is due to that blood pooling, venous stasis. So that's why you see what you see, okay, with those two diagnoses.
Ms. Rumble?
Yes.
I'm sorry. I couldn't hear what you said whenever you were talking about the ulcers, but you did say arterial were going to be like on the toes, right? Like on the top of the foot?
On the top, because think about gravity goes down. I mean, blood flow goes down. So that's where they usually occur. But with venous insufficiency, due to that venous pooling and venous stasis, we see them on the ankle or on the bottom of the feet.
Okay, thank you.
And you can see they look more like this. So again, it's certainly these patients are going to need wound care, adequate nutrition, mobility for blood flow, etc. Our goal is to identify the issue early, as always, teach the patient to do what they need to do so that they don't lose a limb. I mean, that's our priority right there. And like I said, there's all different types of therapies out there, and I'm not going all over that. I mean, you know, for nurses, you need to consult the wound nurse. I mean, we can't do everything. So, you know, consult the wound nurse to, again, try and enhance treatment of that wound. Our priority is trying to get the patient to be safe, to do what they need to do to get out of the hospital, you know. But some of these patients with these big wounds will have to go to wound clinics, wound care nurse. And just like you know, you learn from diabetes. I mean, foot care is imperative. What's the same? I mean, majority of these patients are diabetic, so it's the same. So as nurses, we're going to teach them what they need to do to enhance blood flow, to prevent venous pooling, venous stasis, and hopefully not progress to ulceration, meaning that they get good follow-up care. Another thing, as I said, positioning, remember arteries. Okay, look, can y'all see this? Hold on. Okay. Wait a minute, wait. What did I say? A, this is A. Okay, A, arterial is downward, right? Venous insufficiency is elevate. So that's a good way. Arterial disease, hang them down. Venous insufficiency, elevate. Okay, so that's a good little tool to try and understand that material. So a lot of education that goes into this. You guys know about nutrition. Our biggest concern is preventing infection and loss of a limb, okay? All right, our last topic. Now, remember I said with DVT, that's a very severe, can be a very dangerous diagnosis. So we want to prevent. That's one of the national, core measures now in most Joint Commission and the Joint Commission accredited hospitals, which is prevent. Okay, so, and you know, guys, I need to go over something else. I am so sorry. And that's the medical treatment. So if you will, go back to slide 104. Because this is something you as a nurse need to know. Which, you know what? I'm not trying to confuse you, but I can do it with the other. Let me go to PE. That way we're flowing downward. I can do it with this too. Okay, so with DVT, it's so important to prevent. Why? Because that deep venous thrombosis can move to the lung. Okay, bottom line, it can move to the lung. And you can die from a PE, okay? If the thrombosis is of significant size, okay? So you get less perfusion and you're going to see a patient who looks air hungry. And that is because if that clot size is significant, their PO2 levels and their O2 sat levels will drop significantly, okay? They can complain of pain. I've already gone over this, your wrist. Dyspnea. They are tachycardic, and you may see some jugular venous distension, depending on, all of this depends on the size of the clot. Heart rate goes up, blood pressure goes down. You may see petechiae, again, with significant clots, where it's blocking, causing the little tiny vessels to release blood flow. The best way to determine the size of the clot is going to be a CT pulmonary angiography, and they can identify the size of the clot. So as nurses, it's extremely, extremely important to look at our patients that are at high risk for DVT. And yes, you're giving them the sub-Q heparin or the enoxaparin, but they could still have a PE, and you always have to monitor for that. So again, they have dyspnea, pain, drop in O2 sats, O2 level, and we need to get that CT pulmonary angiography to determine the size of the clot. Okay, so here we go. This is something you need to know medication-wise. If that happens to your patient, you guys should already know you put them in high Fowler's position and administer oxygen because they're symptomatic. The physician should order a heparin drip. Okay. Now, a heparin drip is to prevent more clots from forming. And we're going to give that patient time to hopefully that clot that they have to dissolve. But that takes time. So basically, we're preventing more clots from forming. So as you're starting your heparin drip, you will monitor PTT. Now, how do you know when it's therapeutic? When your PTT is 1.5, I always say keep it simple, 1.5 to 2 times the control. So what does that mean? Okay, so let's say the PTT is, what's normal PTT, guys? Give me a number. Somebody Google it.
$25 to $35.
Okay, so let's say you're just starting your heparin drip. And like I said, you'll learn all about that in 212, how to do the calculations. So you're just starting your heparin drip. So you have a baseline PTT of 25, right? So you're going to recheck that PTT in 6 hours. Now you want that PTT to be what's 2 times 25, 50. So you want that PTT to be 50 seconds. okay? If it's above 50 seconds, it means you're at risk for bleeding. If it's below 25 seconds, it means you're going to clot. So that's what I mean by 1.5 to 2 times the norm, okay? Now, patients doing well, they've been in the hospital, they're going to be going home, they've been there a few days. And the physician gives you an order for warfarin at 6 o'clock, 10 milligrams by mouth. Are you going to give that with the heparin drip still running?
No.
Okay, let me give you a clue.
We can do that with the warfarin, because isn't warfarin a longer half-life?
Absolutely. Warfarin has a long half-life. It takes at least 48 hours to even get a therapeutic level, right? Heparin has a very short half-life. So I am going to administer that 10 milligrams of warfarin because I know it can take a couple of days for that to become therapeutic in their system. Hold on.
So is the heparin given as like a bolus dose to get it in their system and then the warfarin?
Yes, you give a bolus of heparin and start a drip. That's exactly what you do. And then as the patient is getting ready to look at discharge, then you're going to get like a dose of warfarin, 10 milligrams by mouth. Most hospitals give it at 6 o'clock. And that's so they can monitor that PT and INR. Okay. Now, so once I get my PT 1.5 to 2 times the norm, and once my INR is 2 to 3, I can shut that heparin off. It'll be out of that patient's system within, 3 hours or so, and the patient can go home. Now they're going to continue to have lab work done for PT, INR drawn. And that's how the physician will eventually wean that dose of warfarin down until they're stable with their INR and PT, okay? So that is how that works for these patients that are diagnosed with a PE, okay? So just remember that. Your heparin drips are short-acting. Warfarin is a long half-life. So usually about a couple of days before discharge, I'll get an order for warfarin, usually 10 milligrams by mouth. And then I have to continually monitor their INR and PT. I want my INR to be 2 to 3 and my PT to be 1.5 to 2 times the norm. And that's how you transition a patient from a heparin drip to an oral anticoagulant. With your new oral anticoagulant agents, they would have to monitor the anti-10As. So, and it's very important they remain on their anticoagulant therapy. Some of them a year, some of them longer than a year. It depends on, some will be on it depending on their age for the rest of their lives. So they have to make sure they get good monitoring of their lab work. If a patient has repeated PEs, I have seen that happen. They'll go in and put this vena cava filter. It's like an umbrella filter. It actually helps prevent the clot from moving. And they're on long-term anticoagulant therapy. So your responsibilities are prevention with those at risk for DVT. Always monitoring for signs and symptoms of PE, which is, of course, depends on the size of that clot. But if it's significant, those O2 sats will drop, O2 levels drop, they become very dyspneic, very tachycardic, and they can complain of a sharp pain. And it's a medical emergency, guys. Okay, people can die from PEs. So you stay with the patient, put them on oxygen. You need an order for a heparin drip. You know, I've seen many a physician go ahead and put them on the heparin drip and send them for their CT. Get them to therapeutic levels with the PTT, and then transition them to a PO anticoagulant. Okay, let me see. Okay, I know it's getting later in the evening. We've had, or later in the afternoon, excuse me, a lot of material. So our plan will be to, we'll go over the heart failure, the vascular disease of PE on Monday. I'll also go over your 2 assignments I'm giving you. And I will get the blueprint up tomorrow. Okay, I'll get the blueprint up tomorrow. I'm going to go ahead and get your assignments up because I know many of you have clinical, but I'll get your blueprint up tomorrow. Any questions?
I have a question.
Mm-hmm.
So those are all the PowerPoints that we need to study for the exam?
And the pharmacology.
Yes. Okay. I didn't know if there was going to be another one on Monday. So we're just going to review on Monday?
We'll go over, well, I'll always like to go back and reiterate what I've covered, summarized from the previous class.
Okay, perfect.
Yeah, students say it helps.
Yes, for sure.
If I understand it. And then, so we'll go over heart failure PE. We'll go over the assignments. See if you have questions, and probably finish, I would say, an hour and a half at most, so, which I'm fine with that for the last class. You know, that's no problem. Is this the last PowerPoint? Yes. So it's a cardiac farm and this one, which is long. It's long. So there will not be another PowerPoint Monday. No, you will have it. Anything else?
For exam purposes, we only need to know the generic name, correct?
Yes. Okay, you should always learn generic. Yes. It is a lot of material, but I will tell you guys, just like my seniors, they will tell you, if you do what Ms. Rumble says, you should pass the exam with flying colors. You know, if you don't, you've got to apply it. That is the difference in the second year. It's application. And that increases in 212 and then in 213. But you can do it. You can do it. So I have complete faith in you. All right. If nothing else, I will see you on Monday.